Okay, so type 2 hypersensitivity reaction is where your antibodies that are circulating in your bloodstream destroy some kind of cell. And typically, it's some kind of transfused cell that the patient's receiving. So, say for example, someone's getting a red blood cell transfusion and there's an incompatibility with the transfused blood and the patient's blood. So antibodies in the patient's blood will attack the antigens on the red blood cells and destroy the red blood cells. So it's an antibody versus a cell, type 2 hypersensitivity. So transfusion reactions, if a mother has antibodies to the Rh antigen on the fetal red blood cells, that's a type 2 hypersensitivity. Those would be the most common. Okay, so when I think of type 2, I think of antibodies in the patient's blood attacking cells in a transfusion. That's the most common. Now, type 2 hypersensitivity can occur with antibodies that attack cells of the body. So glomerulonephritis is where you have antibodies in your bloodstream that attack certain cells within the glomeruli of the kidneys. Okay, so that would also be considered a type 2 hypersensitivity reaction. We spoke about transfusions as being another one. How about organ rejection? That can be a type 2 hypersensitivity reaction, right? So it's the immune system attacking cells, whether they're transfused cells or your own cells. Autoantibodies, so autoimmune diseases, are antibodies that directly attack the patient's cells. The patient's cells are seen as foreign. The body produces antibodies and directly attacks them. Okay, so that would be an example of a type 2 hypersensitivity reaction. Let me give you an example. So Graves' disease is where you have autoantibodies that attach to the receptor in the thyroid and stimulate the thyroid gland to make tremendous amounts of thyroid hormone. So you get what's called hyperthyroidism. So it's an autoimmune disease and it's an autoimmune stimulation of the thyroid gland. Myasthenia gravis is an autoimmune disease and it's autoantibodies that destroy receptors at the neuromuscular junction, so where the nerve meets the muscles, and you get profound weakness because the receptors in the neuromuscular junction are being destroyed. So another example of where there's antibodies that are destroying certain cells in the body. Okay, so let's look at a question here, a scenario. So a woman who is Rh negative, meaning on her red blood cells, she doesn't have any Rh antigen. And her husband is Rh positive, meaning he has the Rh antigen on his red blood cells. She becomes pregnant with their first child, and the doctor has prescribed Rogam. But the woman is confused about this. She says she does not want to take any drugs while she is pregnant, and besides, the doctor told her that her first child was not at much risk for Rh disease. Okay, so why should she take Rogam if she is pregnant? Why does she really need to take it? Okay, so she's Rh negative, meaning she has no antigen on her red blood cells, and she actually doesn't have any antibody in her bloodstream to the Rh antigen because she's never seen it in her life. Her immune system has never seen Rh antigen. Now she's pregnant and the fetus is likely Rh positive because about 90% of us are Rh positive. So likely her husband is Rh positive. So whenever we have an Rh negative mother that gets, or female that gets pregnant, we just assume that the fetus is going to be Rh positive for purposes of giving RhoGAM. Okay, so she's pregnant now, she's Rh negative, she doesn't have any antibodies to the Rh factor in her bloodstream at all, and now as the pregnancy progresses, some of the fetal red blood cells are going to go into her circulation, and they're likely Rh positive, and they're going to cause her immune system to start producing antibodies to the Rh antigen on the fetal red blood cells. So now her adaptive immune system is forming a memory in the first pregnancy about this Rh antigen on the fetal red blood cells. So that's not going to be an issue in this first pregnancy, because the immune system is just forming this powerful adaptive immunity to the Rh factor. So let's go to the second pregnancy a couple of years later. So she didn't have, let's just say she didn't have any RhoGAM. And now she has Rh antibodies circulating in her bloodstream. And in her second pregnancy, as the pregnancy progresses, she's been sensitized already in the first pregnancy to the Rh factor, or the Rh antigen on the red blood cells. And now she's pregnant again, and so now these antibodies are going to attack the fetal red blood cells during delivery, typically, because that's where a lot of blood exchanges through the placenta. And the baby can be born with hemolysis. So why the hemolysis? Her antibodies that she produced in the first pregnancy are now attacking the Rh antigen on the second pregnancy's red blood cells during delivery or shortly after delivery. Okay, so she really needs to take RhoGAM in her first pregnancy. And what does RhoGAM do? Well, it's just an antibody that attaches to the Rh factor on the fetal red blood cells and destroys it, so that she never develops any adaptive immunity or any antibodies to the Rh factor. And that's all RhoGAM is. So RhoGAM is attaching to the fetal red blood cells and stopping her immune system from ever seeing the fetal red blood cells. Okay, so she needs to take it in her first pregnancy so that she doesn't become sensitized. And then in her second pregnancy, her own antibodies might attack and destroy the fetal red blood cells. Okay, so anyone who's Rh negative and they become pregnant, so any woman who's Rh negative and they become pregnant, they need a RhoGAM shot at around 28 weeks, which is routine. Okay, so that's, I hope that makes sense. If it doesn't, bring it up in a tutorial. Okay, so let's do this question. What is type O blood considered, or sorry, why is type O blood considered the universal donor? Well, if you think about type O blood, so there's no antigens on it. So in the blood of someone with type O blood, the red blood cells have no antigen, right? So we can give type O blood to anybody because there's nothing to attack on the donor blood, right? So let's go through the answers. It has both A and B antigens on the red blood cells. No, it doesn't. It doesn't have any antigens. It has neither A or B antigens on the red blood cells. That's true. It has no antibodies in the plasma. It actually does. It has anti-A and anti-B antibodies in its blood, in the person's bloodstream that has type O blood. And the last one, it has A and B antibodies in the plasma, which is actually true, right? It does have A and B antibodies in the plasma, but that's not why it's considered a universal donor. It's considered a universal donor because the type O blood doesn't have any antigens on it. So when we transfuse it into another patient, there's no antigens on it. In fact, we don't even need to know what the recipient's blood type is if we want to give type O blood in an emergency. We can just transfuse the type O blood because nobody's going to react to it since there's no antigens on the red blood cells. Okay? So when you're thinking about different blood types, think about, okay, what's on the red blood cell? So if you have type A blood, that means you have antibodies to type B blood in your bloodstream. If you have type AB blood, that means you have antigens of A and B on your red blood cells, and you have no antibodies in your bloodstream. Okay, so just go through it methodically in that way, asking yourself what's on the red blood cells, what's in the serum, but what's most important in terms of reactions is what is on the red blood cell that's about to be transfused. Okay, so here's the answer, which is B. It has neither A or B antigens on the red blood cell. So it's the universal donor, right? What's the universal recipient? What type of blood can accept anybody's blood? Well, what about someone with type AB blood? So on the red blood cells, they have antigens to type A and type B. Okay, so what do they have in their serum then? Well, they don't have any antibodies to any of the types of blood because they have the antigens naturally on their red blood cells. So can I give type A blood if I wanted to someone with AB blood? Yes. Can I give type B? Yes. Can I give AB? Yes. And can I give O? Yes again. Okay? So just think about what's on the red blood cell and what's in the serum, which is the opposite of what should be on the red blood cell. Okay? So in this question, there was another right fact that type O blood type patients have A and B antibodies in the bloodstream, but that has nothing to do with why type O blood is a universal donor. So type 3 hypersensitivity, we're not going to spend too much time on, but it's very similar to type 2, except that the antibody and antigen are often free-floating immune complexes within the body. Okay, so within the bloodstream, and then they can go and block up organs, right? So if you look under the examples, systemic lupus, there's a lot of different autoantibodies in that condition. Rheumatoid arthritis, glomerulonephritis, and what can happen is as blood is flowing to the kidneys, you have immune complexes, which are the antibody stuck with the antigen, and they flow through the kidney and get clogged up in the glomeruli. So sometimes it's very difficult to distinguish between type 2, which is a hypersensitivity reaction against cells, and type 3. Okay, so which are more free-floating antibody antigen type complexes. So, and sometimes a reaction or a hypersensitivity reaction can be a bit of type 2 and a bit of type 3. So just understand the basic difference that type 2 is against cells, such as a blood transfusion. type 3 are more free-floating immune complexes in the bloodstream, such as in these examples as well. But remember, there's often overlap in any particular condition between type 2 and type 3. Okay, and here's what's happening in the type 3 hypersensitivity. So your body's made antibodies. It's attaching to antigens that are circulating through the bloodstream, and they are depositing themselves in tiny blood vessels, right? And they can harm the blood vessels by causing inflammation. They can clog up the blood vessels of the kidneys, for example, those little glomeruli, and cause a type 3 hypersensitivity. So again, I would just understand the mechanism of a type 3. By far the most common hypersensitivity and the most concerning is usually a type 1 hypersensitivity, and especially when we're dealing with anaphylaxis. Okay, so just have a basic understanding of what a type 3 hypersensitivity reaction is. Okay, so type 4 hypersensitivity is cell-mediated. And whenever we say cell-mediated, that's going to involve T cells, right? The cell-mediated immunity is T cells. So it's sensitized T cells that then attack the antigens, okay? And it often involves cytotoxic T cells. So the macrophages present an antigen, and the cytotoxic T cells, as part of the adaptive immune system, attack the antigens. So there's no antibodies involved at all. It directly attacks the HLA markers on the foreign substances which have been presented by the macrophages. Remember, the adaptive immune system likes to be introduced to antigens, right? Okay, so what are examples of a delayed type hypersensitivity reaction? Well, a transplant rejection is a perfect example where T cells recognize the transplanted tissue as foreign because of their HLA markers and attacks them and destroys the transplanted organ. A TB skin test, a tuberculin skin test, is a type 4 cell-mediated reaction. So just know a couple of the examples of a type 4 hypersensitivity. Okay? So let's do a question. So administration of certain antibiotics may result in a type 3 hypersensitivity reaction. And the answer is true. Okay? So an antibiotic can cause a type 1 hypersensitivity, meaning an allergic reaction from IgE all the way to anaphylaxis, which is also type 1. It can cause a type 3 reaction because if you're taking an antibiotic and say just over time your body starts to make antibodies to the antibiotic, which is now we'll call the foreign antigen. So now you have free-floating antibodies mixed with the antibiotics as immune complexes that are now getting deposited in different capillary beds around the body. Well, that's a type 3 hypersensitivity reaction. Okay, so for example, there's some antibiotics that don't necessarily give a patient an immediate allergic reaction, but days to weeks later, they feel ill, they feel lousy, they're getting, they're nauseated, and they tell us that they've taken an antibiotic for a week or two, and we suspect that they now have a type 3 hypersensitivity reaction to the antibiotic. Okay? They've made antibodies, and now they have all these immune complexes that are floating around in their blood, sticking to different capillary beds and making them feel really lousy. So when we're talking about a drug such as an antibiotic or other potential drugs that cause a hypersensitivity reaction, meaning that the body has slowly made antibodies to the particular drug, we call it a serum sickness, because in their serum is free-floating immune complexes of antibodies and antigens that are stuck together, the antigen being the drug, and they just get deposited in different capillary beds around the body, making the patient feel awful. Okay, they're nauseated, they feel fatigued, and then we get a history of having taken this drug, and we suspect a type 3 hypersensitivity reaction. Okay, so I hope you know the difference now between a type 2 and a type 3, or it's clear at least.